Bendamustine-Rituximab, BR. Indications. Treatment-naive low-grade non-Hodgkin lymphoma. Treatment-naive mantle cell non-Hodgkin lymphoma, MCL. Relapsed low-grade non-Hodgkin lymphoma. Treatment intent. Disease modification. Pre-assessment. Ensure histology is confirmed prior to administration of chemotherapy. Record stage and IPI of disease CT scan, neck, chest, abdomen and pelvis, and/or PET-CT scan, presence or absence of B symptoms, clinical extent of disease. Consider bone marrow aspirate and trophine. Blood tests FBC, U&ES, LDH, ESR, urate, calcium, vitamin D level, magnesium, creatinine, LFTs, glucose, HbA1c, IgG, 2-microglobulin, hepatitis B core antibody and hepatitis B surface antigen, hepatitis C antibody, EBV, CMV, VZV, HIV, HTLV1, glucose 6-phosphate dehydrogenase, G6PD, when indicated, group and save. Send a group and save sample to transfusion and ensure patient has been flagged to blood bank for the requirement of irradiated blood products for all future transfusions. Ensure irradiation card is given to the patient. Urine pregnancy test before cycle 1 of each new chemotherapy course in women of childbearing age unless they are postmenopausal, have been sterilized or had a hysterectomy. ECG plus or minus echo, if clinically indicated. Record performance status, ECOG. Record vital signs, height and weight. Consent and counseling. Ensure patient has received adequate verbal and written information regarding their disease, treatment and potential side effects. Fertility. It is very important the patient understands the potential risk of reduced fertility. All patients should be offered fertility advice. Assess and document tumor lysis risk as part of pre-assessment. Patients should be adequately hydrated before and after each cycle administration. In bulky disease, prehydrate with sodium chloride 0.9% 1 liter over 4 to 6 hours. Advised dental check is carried out by patient's own dental practitioner before treatment starts.
Treatment should be agreed in the relevant MDT.
Drug regimen.
Days. Drug. Dose. Route. Administration details. Day 1. Paracetamol hydrocortisone chlorphenamine. 1000 milligrams. 100 milligrams. 10 milligrams. Oral 4/4. Greater than or equal to 30 minutes before rituximab. Day 1. Rituximab. 375 milligrams per square meter. 4. In 500 milliliters sodium chloride 0.9%. Max rate 400 milligrams per hour. Patients should be observed for 30 minutes before the start of other infusions. If first dose is well tolerated, consider a rapid infusion rate from cycle 2 onwards. Days 1 to 2. Bendamustine. 90 milligrams per square meter. 4. In 500 milliliters sodium chloride 0.9%. Over 30 to 60 minutes. Cycle frequency, 28 days. Treatment duration, max 6 cycles. Concurrent medications. TLS. Prophylaxis. Cycle 1. Note, allopurinol should be omitted on the days of bendamustine. Antiviral prophylaxis. Acyclovir 200 mg TDS during treatment and for 3 months after completion. PJP. Prophylaxis. Cotrimoxazole 480 mg 3 times a week on Mon, Wed Friday for duration of treatment and at least 3 months after completion. Consider reducing the dose to 480 mg twice weekly during neutropenic periods. Pentamidine can be considered for patients who are intolerant or allergic to cotrimoxazole. Antiemetics days 1 to 2, moderate risk. Ondansetron on days 1 to 2, 8 mg BD. Metoclopramide on days 1-5, 10 to 20 mg TDS. For breakthrough nausea or vomiting, 10 to 20 mg TDS when required.
Contraindications. Hypersensitivity to active ingredients and excipients. Active severe infections. Severe liver impairment, bendamustine. Investigations. Before each cycle, FBC, renal and liver profiles. ECG when clinically indicated, monitor closely in patients with cardiac disorders. Restaging. Consider a response assessment with CT-NCAP after 3 to 4 cycles with the end of treatment CT-NCAP or Peru time/central time. For marginal zone lymphoma, consider stopping at 4 cycles if good response. For other indications, usually continue to 6 cycles. Treatment modification.
Non-hematological toxicities. Grade 3 or 4 toxicities. Discuss with consultant. Next cycle should be delayed until toxicity grade is less than or equal to 2. Renal impairment. Hepatic impairment. Bendamustine. GFR greater than 10 milliliters per minute. 100% dose GFR less than or equal to 10 milliliters per minute. Limited data. Clinical decision. Mild. Bilirubin less than 20 moles/L 100% dose moderate. Bilirubin 20 to 51 moles/L 70% dose severe. Bilirubin greater than 51 moles/L not recommended.
Adverse effects. Rituximab. Infusion-related reactions, IRRs, or severe cytokine release syndrome, characterized by severe dyspnea, often accompanied by bronchospasm and hypoxia, in addition to fever, chills, rigors, urticaria, and angioedema. Hepatitis B reactivation. Bendamustine. Hematological adverse reactions, including leukopenia, thrombocytopenia. Constitutional symptoms, fever, gastrointestinal symptoms, nausea, vomiting. Infections, including bacterial, sepsis, pneumonia, and opportunistic infections, pneumocystis jirovecii pneumonia, PJP, varicella zoster virus, VZV, and cytomegalovirus, CMV. Cases of progressive multifocal leukoencephalopathy, PML, including fatal ones, have been reported following use of bendamustine mainly in combination with rituximab or obinutuzumab. Hepatitis B reactivation. Increased mortality, mainly due to opportunistic infections, was observed in recent clinical studies when bendamustine was used in combination treatment outside the approved indications. Dermatologic toxicities, allergic reactions, urticaria, common. Cases of Stevens-Johnson syndrome and toxic epidermal necrolysis, 10, have been reported in patients who received bendamustine and allopurinol simultaneously. Avoid concurrent use. Patients who experience any skin reactions during treatment should be monitored closely and, in the case of any suspicion of the skin reaction evolving to a serious mucocutaneous reaction, treatment with bendamustine should be withheld until complete resolution of the event or discontinued. Other potential causes of skin toxicity should be evaluated and suspected agents discontinued accordingly. Cases of non-melanoma skin cancers, basal cell carcinoma and squamous cell carcinoma, have been reported.
Extravasation risk. Bendamustine, vesicant/irritant rituximab, neutral. Treatment-related mortality. Less than 1%.
Thank you.